If I could ask the two lawyers on the panel, Norm and John.
I'm not a lawyer.
Are you aware of any case where a judge has ordered a physician, nurse, or other healthcare professional to provide care, treatment to a patient over that clinician's conscientious objection that has been stated to the judge?
Sure, Baby K.
Were the physicians party to that, or was it the hospital that went forward?
Well, hospitals don't treat patients, doctors do. So the order is to continue the treatment.
But were there physicians who testified
Sure.
and said that they didn't want to do this and they were parties to the litigation?
Yes.
I would disagree in a minor but important way. A court can never tell or force or require a doctor or a hospital to treat anybody. What a court does in a case like Baby K and all these other cases is they says, here's our interpretation of what the law is. Here's what we say the law requires. That's all courts can do. If, for example, in Baby K, the doctors, despite the court saying, we think the law requires treatment of such case, if they had simply stopped the ventilator, my prediction is that nothing legally would have happened. A suit may have been brought, but it would have failed with absolute certainty. Based on what? 2,000 years of legal history in which the numerator is zero. There's never been liability found. So, or 200 years of American history. So I don't know of a single case in which a court forced a doctor to treat, because the court doesn't have the power to do that. They don't have coercive powers. They're not going to, as one of our transplant surgeons once said in a case like this, I'd like to see any judge make me do a transplant.
Marcia?
I'm from Texas. At least I live there.
We're sorry.
I'm actually from Virginia, but I landed there. Anyway, Marcia Levittown. My background is critical care and palliative care. But I have one comment, and then I have a second one that I'd like you to comment on. The first comment is that I think whenever we talk about withdrawal of support or withdrawal of care, we are creating the predicted response from the parents. And I think we need to think a lot stronger about providing palliative care and realistic options when the extraordinary or other way you might categorize some of the other interventions we could offer would be the alternative. So that's just my comment. But the second one that I'd like to hear some feedback about is why we're so okay with allowing insurers to make decisions that we're sometimes cowardly not to make for ourselves. So if we say, well, it's okay, we live in this ideal world and we should allow any decision to be made, when the insurance company says, well, we're not going to pay for it, we say, okay, and back off. So just your thoughts about that.
Well, it's interesting. And Bob Veach wrote a very famous article on the Wangley case in which he argued that the insurance company could cut off the funding, but that doesn't really excuse the hospital and the physician from providing for the care. That's what EMTAL is all about. You can't simply dump the patient. What we have is in our society, it's a very individualistic society. We don't have a collective sense of what is the appropriate, and it's very individualistic. And we also have, unlike European countries, we don't have a common source of funding and a common healthcare system. So you can play one physician, one hospital off against the other, and we simply refuse as a society to come to terms with the issue of what do you do when the physician says no and the family says yes.
Well, I would say again, as in Larry's question about the judge, an insurance company can't determine whether somebody gets treated or not. They can say we're not going to pay for it, but that's just one factor that the hospital has to continue to consider in whether to treat. Almost all of these cases, at least the ones I'm involved with, like the child in the persistent vegetative state, are financial losers. That is, either their money runs out or it's not authorized by Medicaid or Medicare. But so there are $1 million cases in which hospitals are losing millions treating patients on ventilators and so on. But I wouldn't say that the insurance company has forced the cessation of treatment. The hospital doctors only doctors can make decisions, and hospitals can obviously influence the doctors. So neither the judge or the courts or the insurance company makes decisions. They just tell you, here's one factor you ought to consider.
And to reinforce that, the very first of these cases was Baby L at Boston Children's, and the attorney there was Frank Ridden. And he called me one morning about 6 and said, "Father, I hope I didn't wake you." I said, "If you're calling me at 6 in the morning, it's precisely to wake me. What's the issue?" And, well, we have Baby L, and the parents have got a court hearing scheduled this afternoon. The judge is coming to the hospital. And what are we going to do if the judge orders us to put the child on a ventilator? This is the case I told you. For 23 months, the child had gone through, the child was conscious. I said, if the judge orders you to put the child on the ventilator, you will decline and you'll appeal. You'll decline. The reason you didn't put it on this morning is you believe it's wrong. And the fact the judge has authorized it, not ordered it, or even ordered it, doesn't mean you're going to do it. And the case in point is a wonderful example from DeKalb County, Indiana. There was a mother of a 16-year-old girl, and the girl stayed out late at night, and mother became concerned about the possible untoward consequences of this behavior, and she goes to the county judge in DeKalb County, Indiana, and gets an order to have her otherwise healthy 16-year-old child sterilized, and produces the order. If she came to any of you physicians with that order, would you feel compelled to do it? You wouldn't do it. And the reason you wouldn't do it is you believe it's wrong. And if you believe it's seriously wrong, you wouldn't do it even if a judge says so. So Noam Fost is right. Depends on how seriously you're willing to confront the issue.
Yeah, I agree completely. Let me be more concrete. Wisconsin has this wacky Supreme Court decision that says, literally, death is never in the interest of a patient, unanimous decision, is never in the interest of a patient in Wisconsin unless they're in a persistent vegetative state or have an advance directive. So children can't have an advance directive, and they're almost never in a vegetative state. Therefore, it's never in the interest of a child in Wisconsin to die. So this Montalvo case tested it, and the appellate court said, the Supreme Court says, never in the interest to die, therefore you don't need consent from anybody to treat because there's no option. So I can't think of a single court decision that's more clear, more simple, more lucid, that, quote, tells the doctors and the hospitals, you may never withhold or withdraw treatment. How often does it happen? Daily. Every hospital in Wisconsin that treats children, including Milwaukee Children's Hospital, which is in the district where the Montalvo decision was made, at least once a week, I'm sure, they withhold or withdraw, or at least often, they withhold or withdraw treatment in gross violation of what the court has, quote, instructed them to do, end quote. Why? Because the court has said, here's what we think the law is, have a nice day. They have decided to practice good medicine. In one of our hospitals in Madison, a community hospital, they have on their publicly available website a statement about these decisions, and they say, we're going to continue to practice good medicine here and take care of patients in collaboration with their families according to what we think is in the best interest of the patient.
I want to give one brief example that's about the issue of courts and institutions that goes the same way, but it's in a completely other example. Many of you may be aware of a court case in Maryland, the Kennedy-Krieger case that involved an evaluation of the court about whether certain research was ethical or not. And in the judgment of the court, whether it was legal, thank you. What they said in this was that children can only be permitted to participate in minimally risky research. And so, which is different from the standard that's used around the country. So in theory, all of the IRBs in the Maryland could have chosen to listen to that court recommendation and done that, but in fact they didn't do that. And so that's another example where those legal opinions become one of many factors that influence decision making.
I was asking about cost driving the decisions, and I worked at an adult hospital for 3 years as the director of palliative medicine, and we had a lot of transplants because it was Bakey's Hospital. Okay. And there was a patient who was homeless but needed otherwise a heart transplant and didn't have money to pay for that. So he was uninsured. He didn't get the transplant. There was another who had inadequate insurance and was a young man, did not get a transplant in his early 50s. At MD Anderson, there was a 32-year-old Iranian woman with a small child with lymphoma that needed a bone marrow transplant for cure, but she only had a green card. She didn't get a transplant, and she died because we only do true free transplants. We don't even do them at all in our indigent care system. You have to go to Anderson. They only do 2 per year, unreimbursed. So, these are not neurologically devastated patients. These are patients who otherwise, some of them might have had a reasonable outcome, yet we still allow the money to drive the decision-making process. And that's what I had in mind when I asked the question.
Yeah, and as I said, and I think Ben agreed if you read between the lines of his talk, of course money matters. If you could, how could it not? That is, if dialysis cost a penny a day, if you could, you wouldn't have big disputes with profoundly retarded children or parents of profoundly retarded children about whether to treat their renal failure if taking a vitamin C tablet would do it. Why would we engage in a debate about that? The only reason we engage in a debate about it is not just because the organ is ultimately limited, but because it costs $1,000 a day to do it. So of course cost matters. Socrates said the beginning of wisdom is to call things by their right name. And I think we should be honest and direct and say, of course the money matters. Just with a comment on David Magnus's talk in that regard too, when you said, David, nobody wants to get on the slope where IQ matters in kidney decisions. Of course we do. That's what the anencephalic, the reason the anencephalic child, why everybody agrees, is because the IQ is so low. Because the child is so profoundly retarded that he or she can't experience any benefit from it. So I think we should face up to the relevance of IQ and of cost, and then try to deal with tough cases.
So just to be clear, what I had in mind was we don't want to go very far down that slope, because we don't want to start saying, well, 90 IQ doesn't deserve as much as 120, 120 doesn't deserve it as much as 140. So I think we don't really want. There's a question about whether there's a line right at the top where we want to draw it.
Well, I respectfully disagree. I think we do want to go down that slope. We want to figure out where on the slope to stop, and there's not going to be a bright line, but clearly it stops at 0, and that is when there's no IQ. And in your other case in which you were divided the Alagille syndrome, in which is profound. So IQ matters. We're just debating about whether it matters of an IQ of 1 or 5 or 10, or where on the line to draw it.
But you'd probably agree, Norm, that if you go on the slope, you should have an ice axe and crampons. We have another question over here.
Somewhat related to the last point that you were making, which is when you were talking about the intervention of parents in these decisions where parents are insisting on treatment that doctors don't think is necessary, it occurred to me that in addition to money mattering, it seems to me that the accident of who your parents are seems to matter disproportionately in a way that nobody really talked about, where people who are strong advocates for their kids, and I'm not talking about the people seeking treatment which has no useful outcome, but the sort of one step back from that, where other parents who are either overwhelmed or for whatever reason can't fully engage in the crisis that's going on in their child's life, say, don't do anything, and the child dies, where another set of parents with more resources, not necessarily financial, but that too, will say, do this, and there is, an outcome where the kid is not dead, has some minimal IQ and all that kind of stuff. So why should the accident of who your parents are matter?
A couple comments on that. They go both ways. First, there was who your parents are obviously can and does matter, even with regard to issues about adherence, which David's group said should be a relevant consideration. If the family situation is such that adherence is likely to be very poor, that should matter. Well, that can be a problem. That is, there was a famous case in Loma Linda some years ago. They had a heart transplant, pediatric heart transplant program in which a child was turned down who was medically otherwise a good candidate because the mother was a cocaine addict, as I recall, and clearly highly unlikely to be cooperative and adherent. There was a firestorm about this because she was black and indigent and so on. And within 2 days, they found a grandmother who was perfectly wonderful and lived close to the hospital. And the transplant was done, and the grandmother simply provided the care. So that's an example that goes that way. But on the other side, I would say there are services that society decides not to provide, like transplants for anencephalic children or home ventilator programs. Some centers decide not to provide, some do for children in persistent vegetative state and so on. And if in that circumstance a very affluent family comes forward and says, all right, the insurance won't pay it, the Medicaid won't pay it, but we'll pay it, and we can afford it. I don't know that there's anything necessarily terribly wrong about that. That is, assuming it's not contrary to the interests of the child. That is, there has to be some inequality in the healthcare system, just as there has to be some in the education system and the housing system and the food system and everything. Nobody wants a society in which if everybody can't get exactly the same thing, then nobody can get it. So as long as everybody has if everybody had a decent minimum of healthcare, I don't know that we should be upset that some people at the very top get something that we're not willing to provide to everyone.
Conceptually, I think it's broader than this. If there's a range of cases where it doesn't fall into the categories that you described earlier of being either obligatory that we have to provide care and it would be negligent not to, nor is it something that it would be futile, there's going to be a range of cases where it could go either way, and it's a value judgment about whether it's appropriate to go forward or not. But under those circumstances, that means for parents whose value systems say it would be appropriate to go forward, those kids will get treatment, and for those parents who don't, they won't. And so some kids will survive or not, depending on the values of the parents. So that just follows logically from the existence of that sort of category where it's not clear what the best thing to do is and that it's a value-laden decision. So I think it's something we have to live with.
Against what you said earlier about children are not chattel. That is, I'm not saying I know what the answer is. I'm just saying notice that if we want to say that children are not chattel in the way that the guy who says if my kid's not perfect, in essence, kill him, right? We all seem to be in agreement that that's not okay. But in those cases, precisely as you describe, is the child of the parents who don't have, and I'm not talking about financial wherewithal, the emotional wherewithal to deal with it, are they less deserving of that outcome than parents who, for whatever reason, do have those emotional resources?
So let me try to respond to that. I mean, I think this really gets back to Norm's point about where do you draw the lines. I mean, in other words, there are clearly some, as were described, some circumstances where treatment would be obligatory, maybe some circumstances where it would be obligatory not to do it. And the question is, how large are those categories? And what do you have in the middle? And I think to a large extent, we want to have that middle band pretty large, rather than just find one single parent who can make that right decision and everybody else is wrong and we can't intervene them. So the idea, I think, is really a question of how much discretion do you want to give parents and how much weight should we give them. And I think in general, the trend is really more for respecting parents' decisions more broadly rather than less broadly, but just trying to define those sort of extreme circumstances. And because of that, we may see a lot of otherwise we may describe as tragic and unfortunate situations, but perhaps the alternative, which would be having one narrow view, would be a whole lot worse.
I think we have somebody in the middle here.
I'm the other person from Texas, I guess, and in fact, I'm from Austin. And in fact, I co-chaired the ethics committee for Emilio Gonzalez. So I think a lot of what this turns on when we talk about, we're back to the discussion of this parent is able to make decisions, this parent's not able to make decisions, is we're not really centering on what we should be focusing on, which is what's in the best interest for the child. And I think it's really interesting that, for instance, when you have a case with Jehovah's Witness, we think nothing of going to court and against the parents' wishes to ask the court to do something to this child, provide blood transfusions. We think nothing of that. And the courts actually think nothing of rendering court decisions so that we can do just that. In the case that was in Austin, there, of course, were a lot of things that were not able to be fully brought out in the press for reasons of confidentiality, although Mom was very free with the information. And it was a very complicated situation. And I think that the hospital, and we've been involved in these cases before, I think that we really do rule on the side of trying to support the parents. But what our committee is always focused on is what is in the child's best interest. And you want to side with the parents, but what you really have to keep your eye on is what is in the child's best interest. And unfortunately, sometimes that means that you are going against them, but that's what we really try to focus on. And I think we make assumptions that parents always have their child's best interest, but there are a lot of situations where characteristics that the parents may or may not have, and I'm not talking about resource issues, I'm talking about mental health issues, I'm talking about just a variety of things, does not allow them to put that child in the central focus, which is exactly what we should all be doing.
Yeah. Doug, do you want to?
No.
Well, I'm going to channel Doug for a moment, and he'll be talking more about this tomorrow, but I think in a very general sense, parents make lots of decisions that are not necessarily in the best interest of their children. They do it for all sorts of reasons, and we allow parents to make all sorts of decisions, some reasonable, some even wacky, unless in some way they're going to really dramatically hurt their child.
I just want to also add that it's important to remember that the notion of what counts as being in the best interest is such a value-laden notion. Mm-hmm. So and that's where it's clear that, like the Jehovah's Witness case, that's why you can go to court. The problem is, what do you do about the cases where we aren't going to have agreement about what's in the child's best interest? We had a case with a 13-year-old cerebral palsy patient who, nonverbal, was starting to have problems with acid reflux, survived on a gastric tube, and the mom who had taken care of this child for the child's whole life decided at a certain point the quality of life of the child was starting to decline to the point where it was in the child's best interest to discontinue hydration and nutrition and to be allowed to pass away. She talked to her pastor, she talked to her pediatrician, she came to that conclusion, and it seemed for that particular child not an unreasonable decision, even though we have other patients who we were taking care of who were very similar state, who we continue to be aggressive. Who's right about what's the best interest of the child is very, very hard to know. And in that particular case, we tend to privilege the parent, partly because this is a parent who loved this child, who knew the child better than anybody and what made life worth living for that child. And so we privilege the parents for a reason in those gray areas, not because it's different from the best interest, but given the value-laden nature of what counts as being in the best interest, the parents' values really should be determinative of figuring out what that is in that gray area.
Yes, and reinforcing that, you say, we'll respect enormously, and Krieger's right, you give enormous range to the parental discretion, and you intervene only when one of the parties believes that what's being asked is wholly antithetical to the well-being of the child. Then you raise the issue. It's sort of, and this is my dispute with Truick, he said, well, you do it even when you think what's being done is wrong. And the example I had, and I talked with Doug this morning, I said, well, supposing the parents are the type that really on Saturday night like to do drive-by shootings. Well, at some point you say, that's your value, but we're not going to respect it. And it has to be that degree of severe antithetical action contrary to what's perceived by not an individual physician, but by the group and reviewed by the ethics committee. And if you still believe that it's wrong, at some point you have to protect the child against what you believe is really wrong.
Norm?
I just want to say two other things about the best interest standard. I agree with everything that's been said. That's where the fights break out, because people can't agree on what's in the interest of a child. But even when you can agree, it's not the only thing that matters. There are other interests that matters, family interests, costs, and so on. It may be in a child's interest to get daily CAT scans, but that doesn't mean we should necessarily do it. It may be, take a less ludicrous example, it may clearly be in a child's interest to have his or her parent's liver or part of or her parent's kidney. It doesn't follow from that that's what we do, that we take the kidney out of the parent, even if they don't want to do it. So there's always other interests. There are always other interests at stake, so it's not the only thing. But I want to say one last thing about best interest, because some people think that ethics is just about talking about things and it doesn't lead anywhere. And that's not true. I think there are many examples in the modern bioethics era in which these sorts of discussions have led to dramatic changes. And one of them is the so-called baby doe issue, that is decisions about withholding or withdrawing treatment from handicapped newborns. For thousands of years, infants with handicaps were killed for most of the time, and then in the modern medical era, commonly had treatments withheld, simple treatments like repair of duodenal atresia and Down syndrome, supported by 70% of American pediatricians in the 1970s. That is, the standard wasn't the best interest of the child. The standard was parental wishes, parental preferences, family goals and interests, and so on. And there was a huge shift in the mid-1980s about that. Won't go into all the reasons for it, but everyone now accepts that these decisions should be directed mainly at what's in the child's interest. It's not the only thing. It's a very dramatic difference when there was strong agreement in the early 70s by pediatricians and others that treatment decisions should be guided by family interests, not by children interests. So it's a shift. It happened because of conferences like this and cases and consensus conferences and so on, and I think it's changed the face of care for children. I don't know of a single case of a child with Down syndrome who's had standard treatment withheld just because he or she had Down syndrome. I don't know in the last 20 years of such a case, and it was common before the mid-1980s.
Two more. Truman?
I think one of the first questions that came up in this question and answer period came from someone who said they work at a hospice organization or had some experience, but didn't ask a question about hospice. And it led me to think that, at least what I can see from the agenda, there's nothing on the agenda about hospice care. And it's been my undocumented observation that there's great discomfort still about hospice care with children, with adults, and significantly with the medical profession. So I'd love to hear some comments about why perhaps it hasn't even, why it's not on the agenda, why it hasn't been addressed, and is this not a strategy that should be considered in more depth by all of you and all of our colleagues in hospitals and medical practice? And if I'm in error about it not being on the agenda, I apologize.
It is on the agenda.
Yes.
Okay.
But we hid the title. Tomorrow,
We hit the title.
tomorrow,